Okay, so respiratory system. Today we're going to be doing one experiment about calculating the respiratory volumes and capacities. But before we go into that, let's first have our general outlines. So, anatomy and physiology of the respiratory system. Anatomy is the structure, physiology is the function. So, anatomically, structurally, our respiratory system is divided into an upper respiratory tract and a lower respiratory tract. An upper respiratory tract begins from your nasal cavity, and your oral cavity. So air would enter through the oral cavity and through the nasal cavity, and it will pass through three layers of the pharynx: the nasopharynx, the oropharynx, and then the laryngopharynx. This air that has entered through the nose, we have the external nares and then the internal nares, and deep in there we have the conchives. These layers are very important because they humidify the air. They condition the air. We mentioned that air conditioning is not just making the air cold in the summer. It's rather conditioning the air to make it homeostatically favorable. So when it is so cold out there, we use the heater to condition the air and make it homeostatically favorable, 37 degrees Celsius. When it's so hot, above 37 degrees Celsius, we humidify the air using an air conditioner, but your respiratory system has its own air conditioner. And these are the mucosa layers that have multiple functions. The first one is to receive the air and pass the air, propel the air downward, conduct the air to your lungs, and also they perform immunological effect. So you have this mucosa layer, it has a lot of receptors that are able to endocytose any debris, any microbes, bacteria, fungi, parasites, and then initiate an immune reaction. So there are sentinel immune system white blood cells that are there to fight and combat the invading microbes that come in with air, that constitute for me a sort of stress. That area of your nasal vestibule, there are a lot of blood vessels. That's why epistaxis, when we have a nosebleed, that means the blood vessels have been damaged, and then coagulation will take place, and those new blood vessels will form to replace the damaged blood vessels. So that area is rich with a lot of blood vessels. Why? To nourish the mucosa layer that is inside my nose. So all of the layers that are here in the nasal cavity, the oral cavity, and then down to the pharynx, it is rich with mucosa, and that mucosa layer needs blood supply, needs oxygen, needs nutrients. It has a lot of cells. So that's why there's a lot of vasculature in there, and that's why it makes sense. There's a lot of blood that hemorrhages in epistaxis and nosebleed. Then we move down in our upper respiratory tract into our nasopharynx, oropharynx, laryngopharynx, and these are muscular layers. So there's a lot of epithelial tissue here. But when we go down from the pharynx to the larynx, now we change. This is no longer a muscular structure. What is this? This is a cartilage structure. And then below the larynx, we have our trachea, which is the beginning of the lower respiratory tract. So now our upper respiratory tract has ended right here. The upper respiratory tract has ended right here, let's say at the trachea. So some conventions consider the trachea, the upper part of the trachea, is the end of our upper respiratory tract, and then from the trachea and below, we will have our lower respiratory tract. We have the nasal vestibules, the oral cavity, and then the glottis the glottis is centered to close for me the trachea to ensure that there is no food particles that will enter through my trachea. And there is a very rich nasal mucosa layer that needs a lot of blood supply. That's why there's a lot of vasculature. It makes sense when there is trauma to the nose that these vessels are broken and there's hemorrhage and there's nosebleed, and then it will not take a long time before your body performs coagulation and to do angiogenesis and new blood vessels are made. And then we have our pharynx, which is divided upwardly to the nasopharynx. Then we move down to the oropharynx that is shared with the oral cavity, then the laryngopharynx, and then the trachea begins. The part of the trachea that divides into giving us these two sides, this is known as the carina, C-A-R-I-N-A. And then we have our two lungs. When we move down from the trachea, we have the bronchi, which the bronchi is the plural. So we have one bronchus, two of them are the bronchi. We have the primary bronchi, then the secondary bronchi, then the tertiary bronchi. And then part of your tertiary bronchi begins to change histologically, to resemble the alveoli. And then lastly, you have the alveoli, which are the central units of gas exchange and respiration in your respiratory system. So we have outlined what is anatomically our upper respiratory tract, what is our lower respiratory tract. Upper respiratory tract is rich with nasal mucosa that conditions the air and ensures that there is immunological defense mechanisms, and it is very expensive to have mucosa. That's why there's a lot of blood vasculature to nourish the mucosa to make sure it remains thick, to provide with oxygen, nutrients, and remove all the metabolic waste. Then as we move down, we have our muscular layer, that is the pharynx. Then we have our cartilaginous layer, that is our larynx. And then the trachea has a lot of rings. The most histologically unique thing about the trachea is that it is held as a tube and does not collapse on itself because it is enriched with multiple cartilaginous rings around it to hold it in place and ensure that the passage of air in inhalation and the exit of air does not cause it to collapse. Then when we enter the lungs, there are a lot of goblet cells. There's a lot of mucus. So now there's not a lot of mucosa layer, but there is something that resembles what the mucosa layer does. There's actually the product. So when you compare your lower respiratory tract, it does not have mucosa, but it has mucus. It has the product. It doesn't have the cells, but it has the product that is secreted by goblet cells. So these goblet cells secrete for me a lot of mucus. We talked about how important mucus is for maintaining pH balance. The mucus is important because it is rich with many antibodies to perform microbial defenses in case that some microbe was virulent enough and escaped all of the immunological mechanisms that were in the oropharynx and the nasopharynx and in the nose. Now the trachea will do the final job of ensuring that microbe does not infect the lung or make its way into the pulmonary circulation. Then the mucus layer makes sure to also lubricate the lung and to ensure that the air that is about to enter into the blood has been fully humidified and conditioned, and there are no microbes, and there's also a lot of cilia. So the cilia are hair-like cells that also help with brushing down and ensuring that the air moves down, diffuses down gradient. If we are inhaling, air is entering into the lung, and exhaling, it helps with brushing the air outside of the lung, outside of the lungs. Okay, and then we move down into the base of the lung, and you will see there is a disparity between the apex of the lung and the base of the lung. The apex of the lung, it has less alveoli and less perfusion, less capillaries. So the most dense amount of capillaries are in the base, the bottom of the lung. The top of the lung does have alveoli, does have capillaries, but there is a disequilibrium. There is a lot, significantly more alveoli at the base in the bottom of the lung, and significantly more capillaries in the base of the lung than in the apex. That is very important. And that is important for ventilation perfusion coupling. What is ventilation perfusion coupling? Ventilation perfusion coupling is your lungs' ability to make sure that it successfully shunt the blood to the base of the lung, not to the apex. So during strenuous exercise, when you're exercising and you need a lot of oxygen, then you will see that the lung will successfully shunt blood upwardly, because now we need extra help. So the lung will utilize the apex more. But usually the lung neurologically also has to be able to ensure that the most amount of blood is shunted to the base, so we can maximize the interaction between the alveoli and the pulmonary circulation capillaries. So that is anatomically, that is structurally. Now let's look at the respiratory system physiologically. Physiologically, the respiratory system is divided into two parts. Unlike the digestive system, which was an upper digestive tract and a lower digestive tract, but then functionally it was digestion part, ingestion part, digestion part, secretion part, absorption part, excretion part. That's not the case with the respiratory system. Respiratory system, only two functional parts and two anatomical parts. The two functional parts are conductive respiratory tract or conductive respiratory system, and that includes everything from your nasal cavity, oral cavity, nasopharynx, oropharynx, laryngopharynx, larynx, trachea, primary bronchi, secondary bronchi, tertiary bronchi, terminal bronchioles, up until some of the tertiary bronchioles. All of that is just conductive. It's conductive, humidifying, immunological. It is only your alveoli who will make for you your second part of your respiratory system, and that is the respiratory part, or the respiratory system. So the respiratory system is divided into a conductive part and a respiratory part. Conductive part is everything except the alveoli, and the respiratory part is the alveoli and nothing else. Now, the alveoli perform for me a form of respiration, which is exchange of two gases. Respiration is not just the uptake of oxygen. It is the uptake of oxygen by your red blood cells, and also the unloading of carbon dioxide. Many people assume it's just all about the oxygen. Carbon dioxide, if you forget about it, it will increase, it will dissociate in your blood to increase the hydrogen proton concentration, and that will decrease the blood pH, and that will increase the acidity. So respiration does not only involve oxygen, it involves oxygen and carbon dioxide. So that was the respiration that happens within the tissue. So then the blood is carried to the tissues. All tissues need blood. Nervous tissue, hepatic tissue, skeletal muscle tissue, smooth muscle tissue. Every single tissue is made up of cells. As long as it's a cell, multiple cells will give me tissues. And these tissues, they need oxygen supply. They need nutrients. Remember, we talked about macronutrients, lipids, that we need to send them into the beta oxidation pathway to get ATP and to get hydrogen protons and to get NAD pluses and convert everything in the electron transport chain into ATPs. Then we take the carbohydrates also, macronutrients, and then we make ATP out of them. We take the proteins, we use them structurally and functionally to make enzymes and structural proteins for the integrity of the tissue. So all of that is carried in the blood. That is tissue respiration. Tissue respiration is when we are looking at respiration at the level of the tissue. But once we actually deliver oxygen, once we actually successfully deliver oxygen to the tissue, successfully deliver macro and micronutrients to the tissue, we have successfully accomplished tissue respiration. Now we need to get inside the cell and do step number 2, which is cellular respiration. Now we need to start glycolysis. That is cellular respiration involving carbohydrates. Then beta oxidation. That is lipid respiration involving lipids. So one respiration happens inside, one respiration happens outside. That's why patients who have genetic defects, who are unable to utilize enzymes that participate in cellular respiration, they have all the oxygen, but they cannot perform oxidative phosphorylation in the mitochondria. They have lipids, but they cannot perform beta oxidation. So they can successfully have tissue respiration, but it does not mean they can successfully perform the cellular respiration. So we must understand the significance of both tissue respiration and cellular respiration. Your respiratory system's job is like the subway. It just gets you to where you need to be, gets the blood to the tissue. Its job is done there. And to take carbon dioxide from the tissue. While everything has reached the tissue, then it is the job of the cells to actually, and your genetics, to ensure that all the enzymes are there to ensure the respiration happens successfully. Then, there's a concept of partial pressures. Partial pressures concept says that the total pressure exerted by gas fluid or liquid fluid in a container. So what is pressure? Pressure is if I sense all the pressure due to collision at the surface of the blood vessel, at the surface of the container. That collision, if I add it, then each single atom or each single component will contribute to the total pressure with a percentage as much as its existence in that mixture. So I know in the air that oxygen is how much of the whole atoms in the air. If I have 100, if air for me is 100 molecules, how many of those 100 molecules is actually oxygen? Yes?
Like only 20 something?
Excellent. Exactly 20 something, because some books say 20, others say 21. What is nitrogen? How much nitrogen? Yes? 78. Yeah, excellent. Some books say 79. So if there is pressure, air pressure, you promise that that air pressure, which is how much? 760 millimeters of mercury. That is atmospheric pressure, PA. 760 millimeters of mercury is the pressure of the air. And I know that oxygen is only 20% of the molecules in the air. Then how much is the total pressure that oxygen can contribute into my total atmospheric pressure is 21% times 760. Nitrogen is 79. So 0.79 times 760, that will tell me how much nitrogen is contributing into my atmosphere, into my atmospheric pressure. So on the exam I can ask you, if the atmospheric pressure happens to be 760 millimeters of mercury, how much is oxygen contributing to my overall atmospheric pressure? So you perform the calculation, 21% times the complete 760 millimeters of mercury. Then we also have to be familiar with Boyle's law. Boyle's law says, and this is driven from PV equals nRT. And I know that nRT is the number of molecules and R is a constant. So the relationship says that whenever the temperature is constant, makes a lot of sense because stasis is constant. So a state of stasis, it's the opposite from dynamic. So that dynamic means changing. Stasis means constant. Homeo means the same. So homeostasis means we stay constant by staying the same. So we ensure that our temperature is 37 degrees Celsius. And your body fights and utilizes a lot of ATP and energy that is exploited from macro and micronutrients to ensure that your homeostasis temperature remains at constant 37 degrees Celsius. Otherwise, we'll have hypothermia and hyperthermia. So if I have constant temperature, which is homeostatic temperature, 37 degrees Celsius, that means the relationship between my pressure and volume will be inverse. The relationship between my pressure and volume are going to be inverse. So that means if my volume goes down, my pressure is going to go up. If my pressure goes up, my volume is going to go down. And that is very interesting. This is physics. Your respiration, your respiratory system obeys physics. How does it obey physics? Well, it is no longer a secret that fluids, whether air fluids or gas fluids or liquid fluids, will only diffuse from an area of a higher pressure to an area of a lower pressure. So that means I have three compartments. I have the alveoli. This is my alveoli. And I have air, atmospheric air. And I have air in the alveoli. And then I have my capillaries that will carry the blood to my tissue. So I have how many pressures? Pressure number one, pressure of the air. Pressure number two, alveolar tissue. Pressure number three, the pressure in the pulmonary capillary. Pulmonary capillary. And lastly, I have the pressure of the tissue. So, in order for me to provide air, all the way from the atmosphere, and then it's going to go down into the alveoli, and then it must cross into the pulmonary circulation, and then pass into the blood and successfully make its way into the tissue. This passage must obey physics, and that is, in order for the flow of any fluid, in this case oxygen, to enter, the partial pressure in the air has to be the highest, the partial pressure in the lungs has to be a little lower so it can flow in, the partial pressure in the pulmonary circulation has to be less, and in the tissue has to be the least. So now oxygen is going to be like a slippery slide in the park, making its way all the way to the tissue. And the opposite for carbon dioxide. In order for carbon dioxide to be exhaled out, that means the partial pressure for carbon dioxide in air has to be the lowest, the least. In the alveoli, has to be a little higher. In the alveoli, pressure of carbon dioxide. In the blood, it has to be a little higher. And in the tissue, it has to be the highest. So that carbon dioxide can flow from an area of the highest pressure. I don't like to say flow, we should say diffuse, because the movement of particles from an area of a higher concentration to an area of a lower concentration, that's diffusion. So we say flow, but we should say diffuse. So now carbon dioxide is going to diffuse from the tissue into the blood vessels, then the pulmonary circulation, then the alveoli, then out in the air. Oxygen is going to be brought in from an area of highest pressure to an area of a mediocre pressure, and then down pressure gradient. Now this pressure modulation, it doesn't happen on its own. Your respiratory system will respond to your nervous system. So now, in order for me, that's what we're going to see in the lab today. In order for me, so now we have two processes. We have two opposite processes. The first one is inhalation. So and then we have exhalation. So they are different physiology, so they will have different anatomy. So in order to achieve the physiology of inhalation, I must have a different anatomy than when in exhalation. And if I want to achieve physiological exhalation, I must have a different anatomy. So I know that to inhale, I need to bring air in. So that means in my thoracic cavity, so these are my lungs. These are my lungs. And that is the diaphragm. And I have intercostal muscles. And I have abdominal muscles. In order for air to flow in while I'm inhaling, the pressure within my respiratory chambers in my lungs has to be the least. And we said from Boyle's law, if my temperature is constant, physiological temperature, that's achieved, and my pressure, I want it to come down, that means I need to increase my volume. How do I increase my volume? I make my diaphragm go down. When I make my diaphragm go down, is that contraction or relaxation?
Contraction.
That's contraction. That is very important. Knowing that the diaphragm moves down is not enough. You need to know the movement of the diaphragm down. Is that contraction or relaxation? So that's contraction. So I contract my diaphragm. And I also contract, this is so important. This is also going to be in the lab. What are the muscles that we utilize in our rib cage that modulate the transverse diameter of the rib cage, the upper chamber? The bottom chamber is regulated with my diaphragm. The anteroposterior cavity within my rib cage, the anteroposterior cavity, also known as the transverse diameter. So I need to increase my transverse diameter upwardly and increase my bottom diaphragm. So how do I do that? The bottom part will be taken care of with the diaphragm by receiving action potentials through which nerve? The phrenic nerve. The phrenic nerve is going to bring down your diaphragm, makes the volume bigger. And then the intercostal muscles. I only use internal intercostal muscles. These are the muscles that modulate the transverse diameter of my rib cage. These are the muscles that regulate my anteroposterior cavity. These are the internal intercostal muscles. So there's two types. There are the external intercostal muscles. So either way, I'm only using intercostal muscles. But one time I'm using internal intercostal muscles, and the other times I'm using external intercostal muscles. So if I want to inhale, that means I want to make the pressure go down, and I want to make the volume go upwardly. And I have two divisions. Bottomward, I make the diaphragm contract and move down, and upwardly, I utilize my internal intercostal muscles, but I don't use the internal, I use the external. So it's very counterintuitive. Inhalation, we use the external intercostal muscles. For exhalation, we use the internal intercostal muscles. So inhalation, we contract the diaphragm and we contract the external intercostal muscles. And that will make the volume so big and the pressure so low and air would flow in. In exhalation, and this is one of the questions in the pre-lab, they will ask you in the pre-lab, which muscles are used during normal breathing? Well, in normal breathing, everything happens with the recoil. So we have recoil elasticity. So we do not utilize the internal intercostal muscles when we are using our tidal volume, when we are taking breath in and taking breath out. It is only when there is expiratory reserve volume, when I want to shunt out in a pulmonary function test, or when I'm sneezing, achoo, I'm removing all of the air extra out. That is when I use my internal intercostal muscles. This point is very important. They're going to ask you that on the pre-lab. And you must remember that exhalation happens spontaneously as a recoil, because I have already stretched the diaphragm down in inhalation, so it will move so easily upwardly back out. And my intercostal muscles, my external intercostal muscles have been contracted so that they can increase my transverse diameter of my rib cage, and then they recoil so easily, and then the air is going to nicely flow out. In exhalation, it happens spontaneously. Only when I'm sneezing, or when there is expiratory reserve volume, then I utilize. Remember, X we utilize in. It's not, don't think inhalation we utilize internal intercostal. No. Inhalation we use external intercostal muscles. Exhalation, spontaneous. But if I need extra exhalation, we utilize internal intercostal muscles. We also utilize the abdominal muscles to compress against the diaphragm some more. So the abdominal muscles are accessory muscles, the same way the diaphragm is accessory muscle. So that when you want to expire some air out some more, so the abdominal muscles press against your diaphragm press against your lungs, and then air flows out. Okay, what else? So this concept is very important. And then they will ask you on the lab, dome-shaped diaphragm. When do we have dome-shaped diagram? Dome-shaped diagram is now when my diaphragm now is moving upwardly like a dome to compress against my lung and squeeze all of the air out. So now I am making a dome-shaped diaphragm to press against the lungs, making the volume really small, which means making the pressure really high, and then air is going to be exhaled out. That is very important. What else? What else was there? Okay, this concept, there is a lot of, you must really understand this slide here, this slippery slide, that air, oxygen has the highest partial pressure in the air, but it has the lowest partial pressure in the tissue. It makes a lot of sense because it's being consumed in the tissue. I'm consuming oxygen in oxidative phosphorylation. I'm consuming oxygen in my electron transport chain as the final electron acceptor. So how can it have high partial pressure? It will not. It will have low partial pressure. But you will have really high partial pressure for carbon dioxide, because now that's a metabolic waste. It is being generated, and you will have high hydrogen proton. You'll have high acidity, and you will also have high what? Metabolites, such as BPG, biphosphoglycerate, which is a metabolite that is a marker for a lot of dumping of metabolic waste that is being generated and being really toxic in the tissue. So you have all the waste, highest pressure over there, propelling everything out. And you have the highest pressure outside here, propelling the useful, positive things are flowing downward, and negative things are flowing outward. This concept is very important. Oh, now I remember what else. The spirometry, which is what this lab is really about. This is not an eraser. I had my hopes up. Is it an eraser? Oh yeah. Okay, I was eyeing this thing. It wasn't an eraser. Okay, so let's do the spirometry. This is what your lab is all about. You understand this? You're gonna do the lab on your own, and it's gonna be a piece of cake. And in the end of the lab, just generate your PDF and send it to my email immediately, and then you're done for the day. Okay, so now we utilize pulmonary function tests. Pulmonary function tests are not diagnostic, but they are a first step. They are like urinalysis. We look in the urine. Is it red? Is there blood in there? Is it coffee-like? It looks like there's blood. Is there pus in there? Are there a lot of lipids in there? So these are first step tests that give us an insight into how successful your respiratory system is working. So what you need to know, we have two diagrams. Remember, there was a conceptual diagram. In the conceptual diagram, we said, let's draw a middle line that represents 0. 0 is equilibrium. So now I am at equilibrium. I'm not taking air in, I'm not taking air out. I'm not taking air in, I am not taking air out. If I so happen to take, so remember, we have normal breathing and we have forced exhalation and forced inhalation. So if I'm taking a normal breath, if I'm taking in, so let's designate this side as the positive side. That's all the air I can get in. I'm going to make that positive because it's coming in. I'm gaining it. I'm gaining air. That's plus. And that's minus. That's air I'm losing. So if I am breathing normally and I'm bringing in air, I'm bringing in plus 500 milliliters. What is that called? Tidal volume. So this is my tidal volume, TV. And what if I exhale? If I now no longer have plus 500, I have minus 500 milliliters. So now I'm losing the air. What does that represent for me? What does that represent for me? Still tidal volume. So when I'm breathing normally, take a deep breath in. I'm not taking a deep breath. I'm not forcing anything. That is my tidal volume. Now, there is one more thing I can do to gain. So if I take a deep breath and then I take a really strong, a very strong deep breath inwardly, that will represent for me my IRV, which is my inspiratory reserve volume, which is the maximum amount of air I can take beyond, in addition to my 500 milliliters that I took in. And that comes out to about 3,300 milliliters. Now, the opposite, on the other side of equilibrium, the negative side, I can, the same way I have inspiratory reserve volume, I can have expiratory reserve volume. This expiratory reserve volume represents for me, the extra amount of air I can expire, negatively lose, bring out beyond my tidal volume that I expired. So this is my expiratory reserve volume. Okay, and then in all the way there is some air that lags behind, that keeps the lung inflated, prevents the lung from deflation, that keeps the lung full and fluffy. That air is known as RV, the residual volume. So these are my main volumes. Now, volumes, when I add them up together, they give me capacities. So, if I add my tidal volume to my inspiratory reserve volume, what does that give me? That gives me my inspiratory capacity. That is the overall capacity of inspiration. So I can inspire 500 in, and then in addition to it, 3,300. Then that is known as IC, known as inspiratory capacity. And the opposite, all the air that can come out is known as the expiratory capacity. And total lung capacity is every single volume that's out there, including your residual volume. So residual volume plus expiratory reserve volume plus tidal volume plus plus inspiratory reserve volume. The four of them added together will give you your TLC, the total lung capacity. And functional residual capacity will ensure for me that I'm only dealing with this side. The functional residual capacity is residual volume plus expiratory reserve volume. So why do we have these, why are we calculating these volumes? Because later on when we learn about obstructive diseases, like COPD, obstructive lung diseases, OLD, obstructive lung diseases. And then we have restrictive lung diseases. I have obstructive lung disease and restrictive lung disease. What's the difference? In obstructive lung disease, what happens is these are all happening in the alveoli. In obstructive lung disease, such as emphysema, such as asthma, such as bronchitis, what's happening is air is so welcome to come in. Air is welcome to enter into the alveoli with no problem. But can air exit? It cannot exit. So that is obstructive lung disease, is when air can come into the lungs, but it can never get out of the lungs. Why is that? Because the lungs have lost the recoil and the elasticity. So there is a collapse of the alveoli. So if I ask you on the exam, collapse of the alveoli leads to what types of diseases? And that, what does that signify? You say collapse of the alveoli means that there is a loss of the recoil capacity of the alveoli, and that means we can receive air, but we cannot get the air out. So remember, you have a balloon. You fill it with air, and then you paste it with hardened clay on the outside. And then when you let go from the nozzle of the balloon, air is not coming out, because now the balloon is so thick, there's mud all over it, preventing it from recoiling back and propelling the air out. That is obstructive lung disease. Restrictive lung disease is the opposite. Restrictive lung disease, I have no problem getting the air out. I have a problem getting the air in. So in obstructive lung disease, air cannot get out. So there is X on the arrow that points outward. Restrictive lung disease, I cannot get the air in. So that means across, or I cannot get across in the arrow pointing inward. What is an example of restrictive lung disease? Tuberculosis. Tuberculosis is, I think, obstructive. There is a major one. There's a major one with the TGF-beta cells. Asthma, you see, I wrote it right here. You see, Judge Judy, you're not paying attention. I've said asthma, emphysema, and what's the other one? Asthma, emphysema, and bronchitis. Those are all obstructive lung disease. I'm now looking for restrictive lung disease. I said it's TGF-beta cells. What did I say? TGF-beta cells dump into the tissue that is healing. That is tissue that is non-regenerative. Remember, we said there is healing by first intention, healing by regeneration, and then there's healing by scar tissue formation, also known as healing by fibrosis. So lung fibrosis, patients who have lung fibrosis due to asbestos or because they're working in the mines, they will have obstructive or restrictive. They will have restrictive lung disease. And when they have restrictive lung disease, do they have a problem getting air in or getting air out? Getting air in. Very good. So, those two, how is that connected to my diagram? We find out whether you have obstructive lung disease or restrictive lung disease by measuring your expiratory reserve volume and your vital capacity. Take a deep breath. So when you take a really deep breath, that means that's a vital capacity. So the vital capacity is everything except your residual volume. So when they take you in the doctor's clinic and you're doing the pulmonary function test, take a really deep breath as hard as you can. So what are you doing actually? You're doing tidal volume, you're doing all in one. You take a really deep breath, that means you took your tidal volume and then you took your inspiratory reserve volume, then they will tell you exhale everything as hard as you can, and then you expel everything out, and that means you have removed your expiratory reserve volume. So now they have the values for the three. So now, after they have all the values, they will tell whether or not you have obstructive lung disease or restrictive lung disease. That is in the lab. So, how does that happen? It happens as following. So what are we looking for? We're looking for the forced vital capacity, known as the vital capacity. What is the vital capacity? I know that a capacity is a sum of multiple volumes. So a capacity is the sum of multiple volumes. What is vital capacity? The vital capacity is the sum of my inspiratory reserve volume, my tidal volume, and my expiratory reserve volume. So when they tell you take a really deep breath as hard as you can and blow out all the air as hard as you can, they are actually telling you give us tidal volume, give us inspiratory reserve volume, and give us expiratory reserve volume, and everything is going to be the FVC, forced vital capacity, which is the same thing as vital capacity. But on the pulmonary function test, it will be called forced because you're forcing everything out. But it's the same thing as vital capacity. Usually, how much is that? 5 liters. When you take all the air in and blow it out as hard as you can, your forced vital capacity is going to be 5 liters. This is very important. When you take a really deep breath in and blow everything out as hard as you can, it will come out to 5 liters. It'll come out to 5 liters. But are they going to wait for you? Are they going to wait for you to blow out all the air, to give you all the time in the world to blow out all the air that you took in? They will wait for you as much as you want to take in all the air in. But when you're getting everything out, they will only wait for 1 second. That's why it's called FEV1. So they will give you 1 second till you expel everything out in just 1 second. And usually you will get out 4 liters. That's for a healthy person. That is for a healthy person. And that ratio is known as FEV1 divided by FVC. So for a healthy, normal person, what am I expecting? I'm expecting 4 divided by 5, which comes out to 80%. So if your FEV1 divided by FVC, the ratio of forced expiratory volume in the first 1 second, comes out to 4 liters, and you already have 5 liters, that's 80%, you're healthy. But if you have obstructive lung disease, things are not going to be the same. In obstructive lung disease, I have a problem getting air out. So what happens is there will be a drop. So the ratio is FEV1 over FVC. I know FVC is going to be 5. I had no problem getting air in. So I will have 5 in the bottom. In the denominator, I have 5. Will I have 4 in the numerator, or will I have more or less? Will I have 4 in the numerator like a healthy person? Will I have 4 in the numerator? Will I have 4 in the numerator? No, I will not have 4 because I'm not healthy. If I have 4, that means I expired out 4 because I'm healthy. But he has a problem getting air out in obstructive lung disease. So I will not have 4. Will I have more than 4 or less than 4? Less than 4, very good. So I will have something like 3 out of 5. So the ratio is going to drop below 80. It's going to come down to 70. And that is the diagnosis for obstructive lung disease, is when your FEV1 over FVC is 70% or less. That's obstructive lung disease. Now, in restrictive lung disease, I can't even get air in. So what happens to all of my volumes? They're always going to drop because I can't even get air in. So when you tell a patient who has fibrosis, take a deep breath in, they're going to go, but air is not going in. So the inspiratory reserve volume, low. Tidal volume, low. Expiratory, then tell them get all the air out. They have no problem getting the air out. But there wasn't air in to begin with, so everything is going to drop. So my FVC that was supposed to be 5 liters in a patient with restrictive lung disease is going to drop down to 4 because not a lot of air came in. And when I am expiring, I'm going to expire. But I'm going to expire a lot of air, but it's going to be definitely low because it's going to be like 3 out of 4 or 2 out of 4. So the ratio is going to be high. So healthy is when you're 80. Obstructive is when you're 70. Obstructive is when you're 70. Restrictive disease patient, restrictive lung disease patient sometimes can have a normal value. But that normal value is misleading because 4 out of 5 is very close to 3 out of 4 because there is a minor drop in the numerator, which is how much air coming out because they have no problem getting air out, but there is a significant drop in the denominator. So when you make the denominator low, the overall number will be high. So the patients who have restrictive lung disease will have 80% or higher. And patients with obstructive lung disease, they will have 70% and lower. So now let's go in the lab and find out. I just want to make sure I did not forgot anything before we go into the lab. We talked about the muscles and the diaphragm, the thorax. What else am I forgetting? Am I forgetting anything? No. Okay. Okay. I guess that's all. It's 52 seconds. I have to find something for the next 10 minutes before I begin the lab. Anybody has a question?
Why do you need 10 minutes? Why do you need 10 minutes? That's a good question.
Oh, I remember what I missed. What are the factors that affect the flow of air from an area of a higher concentration? So just because I now have an area with a higher partial pressure and an area of a lower partial pressure, so air is now going to flow down gradient. There are no other factors. So I have 3 people. So the first factor, we said the disease. Are your alveoli okay? Can your alveoli recoil? And that means you will not have obstructive lung disease like emphysema, bronchitis, or asthma. Are your alveoli fine in the sense that they can receive in the air? You do not have fibrosis. So one factor is pathology. You do not have a disease. What are the other factors that influence for me the flow of air from an area of a higher partial pressure to an area of a lower partial pressure? If I have a cup of water, and I have the atmospheric pressure, that is very similar to my alveoli and my blood capillaries. So in order for oxygen to come to cross from the compartment of the alveoli into the pulmonary circulation, and in order for oxygen to dissolve in the water from the air, atmospheric pressure in the air, and then This is the partial pressure of oxygen in the air, and this is the partial pressure of oxygen in liquid. What are the factors? If I have multiple cups, there is more oxygen that dissolves from an area of a higher concentration to an area of a lower concentration in cup 1. In cup 2 there is less. In cup 3 there is less, but it's the same air. But what are the factors that lead, which also affect here, which also affect your alveoli? What are the factors that affect for you, besides disease, having a disease, that affect the escape of oxygen into the alveoli and the escape of the carbon dioxide from the pulmonary circulation into the alveoli to make its air out? Number 1 is solubility. How soluble is oxygen? What is the main medium that the oxygen gas is trying to dissolve in? It's water. So blood has a lot of plasma. So in order for oxygen to dissolve in the blood, we have to consider the solubility. So just because there's a high partial pressure of a certain substance, so a substance can have the highest partial pressure, but if the liquid we're trying to dissolve it in repels it, it will not dissolve. And you would find another atom or another molecule successfully dissolving and solubilizing in that liquid, even though it has a less partial pressure. What is the other factor? The surface area. So, which is also part of the pathology. If there is a fibrosis thickness, so this layer is so thick, that means the diffusion is going to be impaired. The diffusion is impaired because there is a thickness between that is inhibiting, so the thickness that is inhibiting the passage of my flow. So I have a layer here, but I do not have in the other cups. You will see there is less oxygen dissolving because there's more thickness that this compartment, that this oxygen has to cross in the compartment. What is another factor besides solubility and besides thickness? How about molecular weight? So the heavier the weight of the molecule, the less it's going to dissolve, the less it's going to diffuse. So smaller and less molecules are more likely to dissolve and solubilize than heavier and molecularly denser molecules. And then there's also the surface area. So the larger the surface area, the better the gas exchange and the better the flow of these, oxygen molecules and the carbon dioxide. Which molecule has the highest solubility coefficient, meaning it is the best in dissolving when compared to other gases? Yes? Yeah, carbon dioxide. Carbon dioxide, nobody beats carbon dioxide in dissolving in water. That's actually good, so it can make its way out of my blood quickly, so that I do not have the buildup of carbon dioxide and hydrogen proton. And we have the reaction where in hemoglobin is more likely to uptake oxygen from an area that has a higher oxygen partial pressure and will dump it at an area that has a lower oxygen partial pressure. It will also uptake carbon dioxide from an area of a higher carbon dioxide partial pressure and dump it in an area where there is a lower oxygen partial pressure. Also with acidity. So hemoglobin has a lot of 4 seats, but it does not carry both at the same time. No hemoglobin molecule would carry at the same time oxygen and carbon dioxide. So in one ride, it would carry oxygens and go to the site where there is a drop in partial pressure of oxygen, dump all the oxygen, and then uptake from the higher partial pressure for carbon dioxide region, and then go and dump it into the area of a lower partial pressure. Okay, I think that's enough. Let's now